Hi there everyone, my name is Prerak Juthani. I'm a second year resident at Stanford, and welcome to part 2 of my POCUS series. The first video that we went over is actually the fundamentals of POCUS, and specifically we went over the sources of this entire series, which is this book as well as the POCUS 101 website. This is a book by Dr. Soni. He's a hospitalist. It's a fantastic book. We then went over the fundamentals of the different transducers, but we talked that we're mostly going to be talking a bit about the phase array transducer. And then we talked about how to approach hypotension specifically from a cardiac perspective. And we spent most of that first video talking about the parasternal long axis view, which can be appreciated by having your probe marker on the phase array probe pointing to the patient's right shoulder. And then you usually want to have the probe in the third to fourth intercostal space. And you often want to just do big movements until you can find a picture that looks similar to this, where you're able to see the left atrium, left ventricle, and the aortic outflow tract, or the left ventricular outflow tract, right? And the big thing here is we talked a bit about how to measure the EF. We talked a bit about how to think about pericardial effusions and where to look for them. And we also talked a bit about the Doppler mode of ultrasound, where you can essentially see if you have severe regurgitant valves, if you are able to look at that. That was in the first video. It's going to be linked, hopefully in the description as well as up here. But today we're going to now talk about the second view that you want to look at in the cardiac cycle. And so this is part 2 of cardiac ultrasound. And specifically, we're going to be talking about now the parasternal short axis view. So remember, the previous view that we talked about, this one is the parasternal long axis view. And you'll see that we got this view by having the probe on the patient's chest around here, pointing to the right shoulder, and just by cutting the heart right along this axis, right? Now, the parasternal short axis view. This is actually a very easy view to get if you have the parasternal long axis view. And the reason for this is by getting to the parasternal short axis view, all you have to do is have the original parasternal long axis view and rotate your probe 90 degrees to now start facing the left shoulder of the patient. So you go from facing the right shoulder to the left shoulder. And a lot of what I'm going to be talking to you about today comes from this paper in the New England Journal of Medicine. Specifically, the parasternal short axis view is going to be one of those views, as well as the apical four chamber view, that's going to allow us to now look at the right side of the heart. And the reason why this is important is because the left side of the heart, as important as it is in telling us the ejection fraction and how the heart is doing, the right side of the heart is equally important because it is essentially what the preload of the left side of the heart is, right? Everything has to go through the right side of the heart before it gets to the left. And so in the parasternal short axis view, you're going to again be facing the left shoulder. And if you had a good parasternal long, you're just going to rotate the probe 90 degrees. And when you get to the parasternal short axis view, what you're seeing is you're now cutting the heart from the apex like this. And you can cut it in all of these like cross sections. And when you're doing that, you are now going to see essentially almost two donuts next to each other. And the big donut, generally bigger, tends to be the left ventricle, and the smaller donut on the side tends to be the right ventricle. This is usually assuming you have a normal patient, because we know that the left ventricle should be bigger than the right ventricle, because the left ventricle pumps out to the entire body versus the right ventricle, what usually just pumps out to the lungs. This may not always be the case, specifically if you have patients who have right ventricular strain, which could happen in cases of pulmonary embolism. It could happen if you have pulmonary hypertension. It could happen in a lot of cases where if you have left-sided failure, you actually also then end up getting right-sided dilation. The biggest cause of right heart failure is actually left heart failure, right? And so that's kind of what we're going to talk about. In this parasternal short axis view, you should be able to see this. This is a normal parasternal short axis view. But the one thing that you can often look for in a parasternal short axis view that can be very helpful is called the D sign, literally the letter D sign. And the D sign is something that you may not understand entirely, but I'm going to show you why it looks exactly like a D. So what is the D sign? Well, a normal parasternal short axis view looks like this, a round right ventricle with almost like an eclipsed, a round left ventricle, and almost an eclipsed right ventricle next to it. But let's say you have some form of right ventricular strain. So let's say you have a pulmonary embolus. A pulmonary embolus is a clot in the lungs. The clot in the lungs increases the afterload that the right ventricle is seeing. And when you have that, the right ventricle has to pump against much more of increased pressure, right? Because you literally have something blocking you. And that then leads to the right ventricle having to hypertrophy. And sometimes it actually is just strained a lot more. And what that leads to is the septum ends up getting flattened. When the septum gets flattened, you will actually then see what's called a D sign. The flat septum makes the left ventricle looks like a D. And because of that, that essentially tells you the right ventricle has some stress going on. And that stress could be a lot of things. It could be a PE. It could actually even be pulmonary hypertension. But then you have to think about, why does someone have pulmonary hypertension, right? So usually when I'm doing my parasternal short axis view, one thing I look for is the D sign, specifically in cases of hypotension, because if I see it, I think, okay, maybe the right ventricle is stressed right now. Maybe we need to consider thinking about a PE. So this is the biggest thing to think about if someone's hypotensive. There's other things to think about as well. In the parasternal short axis view, specifically, you can usually see the mitral valve and make sure you have a better understanding of how that's doing in the left ventricle. But for the first time, you're seeing now the right ventricle, which is very important. The next view I want to talk about, we're going to get two views in this video. The next view is called the Apical Four Chamber View. You might be wondering, how do we get an Apical Four Chamber View? Well, actually, the easiest way to get an apical four-chamber view is actually to go back to the physical exam, try to use your hand, put it over the patient's chest, and find the PMI, or the point of maximum impulse. And what that means is, where do you feel the heart closest to your fingers? And sometimes it's easier to have the patient lie in the left lateral decubitus so that the heart is closer to the chest wall. But wherever you can feel their PMI, if you can put the probe directly over the PMI, you will get a beautiful apical four-chamber view. This is my favorite view. It's just so, it's just so beautiful. And it's also really nice to be able to see some of these organs in real time and be able to kind of put a physical picture to a lot of the pathology we're seeing. So when you actually do that, you'll see that the apical four-chamber view usually end up having to put the probe toward the patient's left elbow. And it's usually going to be a bit lower than the parasternal short, and it's usually going to be a bit more lateral as well. But regardless, I usually find it to be a bit closer to like the anterior axillary line on the left side. And if you're able to get it, you're going to be able to see all four chambers, and that's why it's called the apical four. The apical is referring to the fact that ideally the probe is going to be right on the apex of the heart, and you're going to be cutting through the heart, directly slicing it, such that you should be able to see all four chambers views, which is why it's called the apical four. This is a beautiful view, primarily because you're going to be able to see the right ventricle, the right atrium, the left ventricle, and the left atrium. You can then compare the sizes between the two things, and more importantly, you can also calculate general things that you may not have been able to calculate before. Specifically, I'm going to go over the TAPSE, which is referring to the tricuspid annular plane / systolic excursion, and that's all referring to the right ventricular function. And remember, I think the right ventricle is severely underrated, and a lot of people don't realize how important it is, and we often want to make sure we're assessing the right ventricular function, and this is going to be one way to do that. The second thing that this view allows us to do is that it's also going to allow us to see how the right ventricle compares to the left ventricle. Is that if the left ventricle is squeezing, is the right ventricle squeezing at the same time? If the left ventricle is not squeezing, is the right ventricle also not squeezing? Are they both synchronous or are they not? And believe it or not, that in and of itself is going to be really helpful in helping us elucidate what might be going on. So now let's talk about the first of these two things, which is called the TAPSE. What is the TAPSE? I told you it's all about the right ventricle. The TAPSE allows us to see if the right ventricle is working appropriately. The whole point of the TAPSE is that you want to be able to see the right ventricle and the right atrium. And ideally, you want to be able to see the right ventricle, right atrium, and wherever that tricuspid valve is, you want to be able to see it move between systole and diastole. So specifically, you'll see that at the end of diastole, the right ventricle has relaxed, it's cut and full, and you'll see that it's almost out here. And then in systole, what happens is that the right ventricle contracts. When it contracts, this entire aspect is going to move downwards. So the TAPSE is referring to the difference in this one point, this tricuspid annular plane, between the end of diastole and systole. Ideally, between diastole and systole, if the right ventricle is working well, you should see this move down more than 2 centimeters. If you do not see it move down more than 2 centimeters, that can be a sign of, again, right ventricular strain, usually in the form of maybe PE, maybe pulmonary hypertension. And so this is a really good understanding and way to assess the right ventricle, which I don't think people are aware of. And again, there's a lot of small ways to do this. You can turn on M mode, but if you don't know what that is in ultrasound, don't worry about it. I would just focus on seeing, hey, is this point moving? And if it's moving, for the most part, you'll be able to say, like, it seems like it's moving more than 2 centimeters. But if it's not moving, that's also a sign that the heart's probably not working well. The second thing I like to do in this 4-chamber view is that I like to make sure that I can assess the sizes of the two cavities. As I said, the left ventricle should be about 1.5 times the size of the right ventricle. And why is that? The left ventricle pumps out to the entire body versus the right ventricle, which only pumps out to the heart. So you expect the left ventricle to be a bit bigger. Interestingly, also, if you do the apical 4 view, you should see that the apex of the heart is made up of the left ventricle. It should not be made up by the right ventricle. But if patients do have right ventricular hypertrophy, you'll see that this apex ends up being made by the right ventricle. And again, that's a sign that it's not normal. Usually for a normal right ventricle and left ventricle, the right ventricle should be less than 2/3 the size of the left ventricle, and the apex should be formed by the left ventricle. And if that's not the case, then you know that there's something abnormal. And above all of this, you can also always turn on Doppler mode. You can make sure that the valves are working appropriately from the left atrium to the left ventricle, from the right atrium to the right ventricle. And as long as you have this view, you can actually get a lot of these small nuances. And again, this is all about hypotension, right? So if someone is hypotensive, now you actually know how to assess the parasternal short axis view, check for right ventricular strain. And now that you're in this apical 4 chamber view, you can also check for the size of the relative chambers, and you can also assess a TAPSE to see if the right ventricle is working appropriately. Some other small nuances that you can do bonus things with is you can assess the size of the right atrium and left atrium to the left ventricle and right ventricle. And believe it or not, sometimes if people have severe dilation of the right atrium and left atrium, you might even see them be as big, if not bigger, than the left ventricles. And that is something that's pretty wild. So hopefully in today's video, now you have 2 more views. In the first video we went over the parasternal long axis view, which you can see right here. That was in video 1. But in today's video, we went over the parasternal short axis view, as well as the apical 4 chamber view. And in the next video, we'll be going over the subxiphoid view, which is also fascinating and super helpful when you have a patient with hypotension. If you enjoyed this video, please drop a like, comment, share, and subscribe. I'll see you all in the next one. Peace.